good evening. Thank you all so much for joining us for week 3 of MDA's ALS virtual learning series. My name is Kayla White and I'm a community education specialist at MDA. We're thrilled to have you join us today for this webinar. This learning series is part of our larger MDA community education programming, which focuses on bringing the neuromuscular disease community together around education and resources. Be sure to visit the community education section on mda.org for updates on upcoming events. We are recording today's event and we'll be posting it to the website for on-demand viewing at a later date. Please know that all phone lines have been muted, but we will have a question and answer session at the end of the webinar. Feel free to use the chat feature to send in your questions as you think of them, and we'll get those addressed at the end with our special guest today. I would also like to thank our webinar supporters, Mitsubishi, Tanabe, Pharma, America, and Cytokinetics. We would not be able to provide community education webinars like this if not for their generous support, and we are very thankful and appreciative. For over 70 years, MDA has led the way in accelerating research, advancing care, and advocating for the support of our families. MDA's mission is to empower people living with muscular dystrophy, ALS, and related neuromuscular diseases to live longer, more independent lives. Our mission comes to life through the 4 pillars of care, champion, catalyst, and community. If you haven't done so already, we invite you to join the MDA community by registering with us. I would now like to introduce today's guest, Dr. Jason Ackrivo. Dr. Ackrivo got his medical degree from Rutgers University and completed residency at Boston Medical Center. He's board certified in critical care medicine, internal medicine, and pulmonary disease. Dr. Ackrivo is the Associate Director of the Fishman Program for Home Assisted Ventilation and an Assistant Professor of Medicine at the Hospital of the University of Pennsylvania. So thank you for being here, Dr. Ackrivo. We really appreciate your time, and the floor is yours.
Thanks so much, Kayla. Let me work on sharing my screen. So now you should be able to see my slides. It looks like
Looks
yes. Great. Okay. Thank you, Kayla. So thanks so much, Kayla, and to the Muscular Dystrophy Association, and really thanks to all of you for joining today and taking a proactive approach to learning more about ways you can care for ALS and improve your health. My name is Jason Ackrivo, as I mentioned. I work at the University of Pennsylvania in the Home Assisted Ventilation Clinic there, where I have a large population of patients with various different neuromuscular diseases, including ALS. I have no financial disclosures, but I have several active research projects with funding resources, as you see here, which include the NIH, the Muscular Dystrophy Association, as well as the ALS Association, because a lot of my research also is looking at the respiratory care of individuals with ALS. So what am I hoping to share with you today? So my objectives are to help you understand what are the potential respiratory complications that can occur when you're affected by ALS. Discuss some of the treatment options and or preventative measures they can take as it relates to pulmonary health and ALS, and what you can do to take charge of the pulmonary health by recognizing signs and symptoms and knowing when and where to go for evaluation. So let's first start with just understanding how does ALS or neuromuscular disease in general affect breathing. Well, to understand how this works, it's important to understand the different parts of the respiratory system. There's really 3 vital organs that all kind of work together. It's not just the lungs. There's many components. It involves the lungs, the central airways, and then the respiratory pump. And I'll get into each of those in detail in the coming slides. So first, starting with the lungs, shown here in purple. The lungs, their job is to participate in what we call gas exchange. A lot of us are familiar with oxygen. Their job is to breathe in oxygen that gives our bodies energy And then, as we'll detail in a few slides, this oxygen is eventually converted to carbon dioxide or CO2. And that CO2 is toxic to our bodies and needs to be removed. And one of the ways we remove it is by breathing it out. And so the lungs are responsible for gas exchange by pulling in oxygen and breathing out carbon dioxide. And I'll get into that a little bit more in a moment. The second part of the breathing system is the central airways. So beyond the lungs, looking above the lungs, the respiratory system begins at the tip of the nose and in the mouth and going all the way back to the throat, including our vocal cords and where we swallow, and the central airway is called the trachea, going down and then splitting into both lungs. And so a properly working respiratory system also includes the ability to safely pass air through these pipes into the lungs and to safely be able to swallow without accidentally having things go down the wrong pipe. And then third is the respiratory pump. The main breathing muscle in the body is the diaphragm. That's a plate-like muscle right under the lungs, shown down here, that moves up and down to help pull air in. It moves down to help air move into the lungs. And then when it relaxes, it snaps back up and air goes out. But recognize that the diaphragm is not alone in being your only breathing muscle. It can have other muscles, sometimes called accessory muscles, and muscles throughout your chest cage that can help assist it. I have a diagram here that actually shows the chest wall with your ribs and all of the little muscles that are in between your ribs and around your ribs and up in your neck and down in your abdomen. They all can work together to help the diaphragm if it's weakened. So, for example, somebody who does not have any neuromuscular disease, but for example, if they were to run a marathon, you might actually see somebody at the finish line of a marathon kneeling over with their chest heaving and all their muscles in their chest wall and their neck working together to try to help get in as much air as possible. The same thing goes with if you have neuromuscular disease and you have a weakened diaphragm, we can start to incorporate some of these other muscles to help the diaphragm breathe. So it's important to learn to recognize this, or really your lung doctor has been trained to recognize this as a sign that your breathing might be weakened. So how does muscle weakness affect my breathing? We talked a lot about the muscles themselves and the components of the respiratory system, but how does it actually affect your breathing? Well, going back to what we mentioned before with the gas exchange, on the top left here, if you have neuromuscular disease, you have weakened breathing. And this weakened breathing can lead to smaller breaths and fewer breaths. And the idea here is that if you're not breathing as much as you should be, you're not able to pull in oxygen like you normally could, and you're not able to breathe out the carbon dioxide. And so what we actually get is this elevation in carbon dioxide, which in turn causes oxygen to fall. And I'll give you a little bit of an analogy to help you with that, because it can be complicated. Think about a car, just an old-fashioned, no electric cars here, just old-fashioned gas-powered automobile. We put fuel in the car to help the car go. Same thing with our bodies. We put oxygen into our bodies to help our bodies go. When a car burns fuel, it converts that fuel to a waste product that goes out the exhaust of the car because the car doesn't need it. Same thing with our bodies, with our lungs. If we breathe in oxygen, we burn the oxygen and then convert it to a waste product. And this waste product is carbon dioxide. And we need to breathe that out. But if your breathing is weakened by neuromuscular disease, you're not breathing as much as you should be. And therefore, instead of the carbon dioxide being breathed out, it's building up inside you. When that happens, carbon dioxide can only fill so much space in your lungs. Eventually, it's going to crowd out the oxygen, and that's what ends up causing the oxygen to fall. So oftentimes, somebody with neuromuscular disease who has low oxygen on a typical vital signs check might actually have high carbon dioxide or high CO2 as a reason why the oxygen is low. And that's a really important concept. Now, a little bit more about the diaphragm. The diaphragm, as I mentioned before, as shown on the left side of this diagram here, moves up and down. It moves down to help air move in. And when you're upright, like this person in this picture on the left here, gravity helps the diaphragm move down. And it's also pulling all the belly organs that are below the diaphragm down and out of the way so that the diaphragm can move up and down nice and easy. But when you lay down, whether you have neuromuscular disease or not, you lose that advantage of gravity. The gravity is actually pulling down now on the abdomen. All the belly organs are pancaking out and pushing up against the diaphragm. And the surface that you're laying on pushes up against the surface of the chest wall. So all these forces, the restriction on the chest wall, the restriction on the diaphragm, all make it more difficult for the diaphragm to work when you're laying down flat, whether you have neuromuscular disease or not. But if you have neuromuscular disease and you have weakness of the diaphragm, then this is exaggerated. And so this can lead to difficulty with breathing while lying flat, and which can lead to issues at nighttime, as I'll get to on the next slide. So what ends up happening is the first signs of weakened breathing from neuromuscular disease actually start in sleep. The weakened breathing can lead to the diaphragm weakness, as I mentioned before, which can actually interfere with the deep sleep. Why? Because we've evolved to have as many muscles as possible paralyze when we go into deep sleep so that we don't act out our dreams. But we've evolved to have a few muscles still functional in deep sleep. Your heart's obviously still beating, and your diaphragm is still working to help you keep breathing. And that's the difference is in deep sleep, it's only the diaphragm. All the other muscles are paralyzed. So if you're using accessory muscles to help with a weakened diaphragm during the day while you're awake, you don't have that advantage when you go into deep sleep. You're only at the mercy of the diaphragm. And if it's weakened, what's going to end up happening is your breathing falls way behind when you get into deep sleep. That's going to lead to the carbon dioxide elevation that I mentioned on the previous couple slides. And that carbon dioxide elevation going up sends a very powerful signal to your brain to breathe. Actually, if you ever tried to hold your breath, not saying you should do it right now, but if you were to try to hold your breath for as long as you can, that message that's going to your brain that tells you, hey, breathe, 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 that's carbon dioxide. It's a very strong signal to our brains. We're very sensitive to it. So what ends up happening? Well, when you try to go into deep sleep, this carbon dioxide goes up, and all of a sudden your brain is saying, hey, breathe, breathe, breathe. So what do? You wake up, or you have a micro, subtle awakening that prevents you from going into deep sleep. So you actually have multiple awakenings overnight. You might not be able to perceive all these awakenings, but you're not in deep sleep. You're in a lower stage of sleep or less deep sleep. And yet the sleep is interrupted. So the sleep quality you'll feel like your sleep quality just isn't as good, or you might even notice that you're wakening up. And sometimes early on, it may not be noticeable at all or very subtle, but this is where the symptoms tend to begin. So some of the other symptoms that you might to look out for early symptoms of failing respiratory muscles are, as I mentioned, interrupted or non-restorative sleep. This can also lead to morning headaches. All that carbon dioxide flowing in our blood going to the brain actually causes headaches in the morning. It can cause confusion and brain fog. These are symptoms of elevated carbon dioxide. Fatigue, excessive fatigue, the feeling like you need to take a nap regularly, and daytime sleepiness. It might lead to shortness of breath just with ordinary activity. As I mentioned before, breathing discomfort while lying flat, and also weak cough. I didn't mention it much earlier, but all of those respiratory muscles that I mentioned earlier are involved with the coordination of coughing. And so weakness of the breathing muscles and the throat muscles can actually lead to a weak cough. And we'll discuss the weak cough in a little bit later. So what are my treatment options? If I have weakness of my breathing, what are the options? So some simple things that you can do, at least initially, are to help with improving your diaphragm function. And remember how I said it's weakest when you lay down flat. So one easy thing you can do is just sleep at an incline. Some people, if it fits within your budget, you don't have to necessarily buy a reclining bed. You could buy a wedge pillow, which you can find online for about $40 or $50 if that fits within your budget. And what this is it's a flat, stable surface that keeps your body at a consistent incline. This is more stable than just stacking up pillows, which are prone to move overnight. And it provides this elevation of the head above your waist so that, again, gravity is helping pull the belly organs down and out of the way so that the diaphragm can move easier at nighttime. Some people have back pain or back problems or hip and joint issues, and they're not able to lay at this position. So another thing you could actually do is raise the back two legs of the bed up. Some people put bricks or cinder blocks under them. There are these bed risers that I'm sure if you or anybody, my understanding, going off to college likes to buy these things so they can raise their bed up and store things under it. And these are bed risers that you can use to raise the back two legs of the bed so that the whole bed is at an incline. And so your body is still more or less flat, but your head is elevated above your feet, and it helps with the mechanics of your diaphragm. Again, in the same way I just mentioned. So beyond those simple things, there is a way to help assist your breathing muscles using a treatment that has several names. You might hear it called BiPAP, also known as bi-level ventilation or non-invasive ventilation. Also, another word for these types of machines is a ventilator. I might use these words interchangeably, but the concept is the same. It's a machine that provides a certain amount of pressure through a mask and that pressure is used to help inflate your lungs. It takes the work of breathing off of your muscles so that the machine does the work of breathing, not as much. So it eases the work of breathing on your breathing muscles. And by providing this assistance, it helps relax your muscles when they're at their weakest so that you have energy for the daytime. So typically your breathing is weakest at night. So this is usually, at least initially, prescribed to use overnight to assist your muscles when they're the weakest so that you have more energy for the daytime. It can also allow you to go into a deeper sleep. How does it work? Well, again, I'll use the words interchangeably: non-invasive ventilation or NIV or BiPAP. The way it works is it provides an additional amount of pressure to help inflate your lungs. This is different from CPAP. So some of you might have heard of CPAP or maybe even been prescribed CPAP at some point. CPAP is one single pressure through the mask. Both of these people here have non-invasive ventilation with the mask on. And CPAP is just a single pressure, whether you're breathing out or breathing in, it's at one pressure. It's not really moving additional air. All it's doing is providing a column of air to help open up the airways. That's why it's usually used for something called obstructive sleep apnea, just to help keep the airway open overnight. BiPAP, or non-invasive ventilation, or ventilator, all the same thing. What that does is it provides a lower pressure while you're breathing out. And then when you breathe in, the pressure increases and goes up. And that added amount of pressure helps push air into your lungs. And that helps move air in and out of your lungs. And then it goes back down to the lower pressure, and then back up, and then back down. That's what helps the lungs inflate. It helps move air in and out of the lungs. And that motion of air going in and out of the lungs helps your lungs participate in that gas exchange that we mentioned earlier. And that's what helps bring the carbon dioxide levels down. That is something that BiPAP, or non-invasive ventilation, can do that CPAP cannot do. Again, because BiPAP is helping move air in and out of the lungs. There's a lot of different options out there. A lot of different technologies been developed in the last 10 to 15 years that can help improve pulmonary care for people needing assistance with their breathing at home. So what are the goals of home-assisted ventilation? Well, there's several-fold. One is uninterrupted or restorative sleep. Realize that everybody once in a while has a bad night's sleep, but the goal here is on the whole to improve the quality of sleep. And thereby, the second bullet point, have comfortable breathing when awake, because your muscles have been rested overnight and it can improve your work of breathing while you're awake. And through all of this, we can hopefully normalize oxygen and carbon dioxide levels. And then a related but separate goal, the last bullet point here, is to protect the airways and the lungs. We want to make sure that if our breathing's already weakened, we don't want to weaken it any more than it needs to be by getting things like respiratory infections, pneumonias, things going down the wrong pipe. So we want to protect it from injury. So the machines I was mentioning before, the bi-level devices and ventilators, actually help with the first three goals. And in the United States, at least, they separate the types of breathing machines into two groups. One is a kind of more simple bi-level device, which I'll show on the next slide. And then the second is a more advanced device known as a ventilator. But they more or less do similar things. It's just the ventilators have additional functions, which I'll get to in a moment. In the United States, bi-level devices, there's very few of them. More or less, there's one or two options right now. And the most common one is what's shown here is the ResMed AirCurve 10. It's not necessary for you to understand exactly what this machine is or what type it is and the name of it, but just realize that the simpler bi-level devices are smaller than the ventilators. They don't have internal batteries, so they're not portable. And they can deliver a variety of different modes, which controls how the breath is delivered, but they can only deliver one mode at a time. Whereas ventilators, as I'll get to in a moment, can have options for having different modes. For example, one for the night and one for the day. If you're starting to need assistance with your breathing beyond just nighttime, if you're needing assistance with your breathing into the day, for more than an hour or two or three, and especially if you need to be portable, you need something more than what this device offers. That's when you start needing a ventilator. And a ventilator, again, same thing. It's a tube. It has a tube going from the machine to a mask. It can also be used with a tracheostomy, but it doesn't have to be used with a tracheostomy. It can be used with a mask as well. And these ventilators, these are some of the more common ones shown here. These have internal batteries so they can be portable for on-the-go use. They have more options for the different types of modes that you can use, types of ways to deliver a breath. And you can program in multiple different programs or presets so that you might have a preset setup that you use during the night, and then a separate one that you use during the day, and then maybe even a third one that you use when you're sick. There's a lot of different options that a ventilator has that a more simpler bi-level or BiPAP device does not. And it ends up becoming a little bit of a patient preference or sometimes the clinician preference, but on the whole, a ventilator really tends to be a better option, especially when portability is a need and when you start needing to use assistance with the breathing beyond just the nighttime, or if your disease is rapidly progressing. Now, I've talked just about the breathing machines themselves, but as important are the masks. And masks can be a highly personal decision. I like to use the analogy that finding the right mask is like finding the right pair of shoes. When you go to a shoe store, there's many different shoes on the wall. Why? Well, that's everybody likes different shape, a different color, a different fit, style, function. Same thing with masks. We have masks like shown in the top row here that use just the nose, or masks as shown down here that cover the nose and the mouth. There are masks that go over the bridge of the nose as shown in the panel D, as in David here, and full face masks that go under the bridge of the nose. For people who might move around a lot at nighttime, there are masks that have an extra pad contact point on the forehead, as shown in the bottom two panels here. Nasal mask and full face mask here. So the point here is that just like, again, sticking with the shoe shopping analogy, just like when you go shoe shopping, you might have to try on several different pairs of shoes till you find the one that you like. You might have to try several different masks before you find the one that really works for you. So don't be discouraged if the first mask or the second mask or the third mask that you use or that you try doesn't work as well for you. You might have to go through a few trial and error iterations before you find the mask that really works best for you. And sometimes mask replacements can be a limiting factor for patients depending on their insurance, and they only pay for a mask replacement every so often. Recognize that there is online mask shopping. CPAP.com, CPAPshop.com, or CPAPsupplyusa.com are all different online vendors that you can find the mask that you like and shop for it on your own terms if that fits within your budget. So how do I end up on assistance for my breathing? Well, you may notice that when you go to your neurologist, they do some breathing tests to measure the strength of your breathing muscles. One of these maneuvers is the forced vital capacity, or FVC. That's the amount of air that you can breathe out from a fully inflated lung, and when you're pushing all the air out as forcefully as you can. What this does is it predicts how much air you should be able to move based on your height and your age. And then they see how much air you actually move, and it creates a percentage. And if you get less than 50% of what they predict you can do, by Medicare criteria, then Medicare or your insurance company would pay for the cost of having non-invasive ventilation at home. Another breathing test you can do to help qualify is something called the maximal inspiratory pressure, or MIP. This is a maneuver where you breathe in through a device as hard as you can. You just inhale as strong as possible. And the cutoff for normal is, it's measured in negative numbers because it's a negative force, is -60. So if you can't generate -60, meaning a higher number, which is such as -30 or -40, if that actually is another way to qualify for a non-invasive ventilation machine at home. I've found that most clinics tend to measure the FVC. Sometimes they measure the slow VC or SVC. Some clinics, I think a lower percentage of clinics measure the MIP. So not every clinic does, but it is another option. Another option, in addition to daytime respiratory strength testing, is an overnight pulse oximetry, or an overnight oxygen sensor that rests on your finger overnight, and it measures your oxygen levels throughout the night. The cutoff here is an oxygen saturation of less than 88% for at least 5 minutes. If you have an oxygen saturation less than 88% for at least 5 minutes, according to Medicare guidelines, and most insurance companies follow this, they will pay for a breathing machine overnight, pay for you to use a non-invasive ventilation machine at home. A lot of these cutoffs are a little arbitrary, and happy to get into that if anybody wants to talk about it, but those are the rules and those are the ones we have to live by. So how does non-invasive ventilation help me if I'm on it? Is there any evidence? Is there any research? Well, it turns out there is. Back in 2006, it was the first and will be the only randomized trial of ALS patients, where they took ALS patients and randomized them to receiving non-invasive ventilation or no non-invasive ventilation, as shown in the two pictures here. It was only 41 people, so 19 people did not get non-invasive ventilation and 20 did. And then they followed them forward in time, and they found that those who were prescribed non-invasive ventilation on average lived about 205 days longer than those who did not use non-invasive or never prescribed non-invasive ventilation. They also noted that people who used non-invasive ventilation had an improved quality of life as well. So this was kind of what we call the landmark trial to show that non-invasive ventilation has a survival benefit in ALS. But it was a bit of a small study, and so people were interested in, is this a real signal or not? So there was a group in Australia that said, hey, if people use non-invasive ventilation more, do they get better outcomes if they use it more? So there was a group actually at University of Pennsylvania, led by myself and others, who said, you know what, let's take a look at people who actually use their non-invasive ventilation. So what we ended up doing is we gathered a cohort of patients who had ALS, and these were patients that they were not randomized. This was 10 years worth of data where some patients chose not to be on non-invasive ventilation and some did. And so we took the people who did choose to be on it versus those who didn't and compared them and followed 10 years worth of patients. And we found that people who were ever prescribed non-invasive ventilation actually had about 26% lower risk of dying at any point by just being prescribed non-invasive ventilation. This was regardless of how much they actually used the device. So what we ended up doing was we took the group of people who did use non-invasive ventilation, so the people who were on the device at all, and we separated them into two groups. One group who on average used it less than 4 hours a day, and the other group who on average used it more than 4 hours per day. So it's really trying to separate out, if people use it more, is there an even greater benefit? And we actually found that there was. And people who, again, this is on average, used it at least 4 hours a day had about 33% less risk of dying at any point. Now, obviously, there's a lot of ways you could look at this data, and it was not a randomized study like the one I described earlier, but it was several hundred people. And so again, I think that this lends weight to the argument that if you can get non-invasive ventilation to work for you and you're able to use it regularly, it likely does have a survival benefit. Now, I mentioned a lot about non-invasive ventilation. What about protecting the airways and the lungs? How can we prevent it from injury? Well, as I mentioned earlier, having a good cough is a protection mechanism to prevent things from going down the wrong pipe. And we can actually measure the strength of your cough in clinic. It can be done using an old-fashioned peak flow meter, which if you know anybody with asthma, they tend to have one of these at home, and you just cough into the peak flow meter. Or your team at the clinic could have you cough into the spirometer, the same device that was used to measure the FVC earlier. And there's a number that's spit out there that could actually measure the strength of your cough. If your cough is weak enough, you can actually qualify for something called a cough assist device. The fancy medical term for this, in case you've heard of it by a different term, is called maximum insufflation exsufflation, or MIE. The bottom line is it's a cough assist device, and these are meant to strengthen or to help you cough, even if you can't cough on your own. What it is a device about the size of one of the ventilators that I showed earlier, with a tube that goes to a mask or a mouthpiece if you have the strength. And it simulates a cough by providing a high amount of pressure in to help inflate the lungs, and then immediately followed by a high negative pressure, like a vacuum, to help pull all that air out of the lungs rapidly, just like you would when you cough. The cough starts with a big deep breath in, you hold your breath, and then you cough, and then you forcefully push it out. The machine is basically simulating that for you. And you don't even need to be able to coordinate your cough with the machine. Even if you have an extremely weak cough, this can still simulate that action for you. And it's great because it helps remove things from the big airways in the middle of your lungs that tend to get mucus trapped, sometimes mucus plugs. And that's where we can help remove those things so that it doesn't end up causing an infection or pneumonia. Can help keep you out of the hospital if you get a bad chest cold. Literature in the use of cough assist device. So these, there's not as much literature, I think, focused on cough assist device as there is on non-invasive ventilation. But from as far as we can tell, it's kind of intuitive. It helps improve the cough force. Some patients have noted that it helps improve the pattern of their breathing. Regular use, even when you're not sick, it's thought that it can be like like a physical therapy exercise for your chest, helping expand through a bigger range of motion than it normally would. So it can help improve chest wall flexibility. And we think it might help decrease the likelihood of being hospitalized, developing respiratory infections, and through that, may actually end up improved mortality, although I don't think that that's actually been proven, but intuitively it makes sense. So if I'm using non-invasive ventilation over the night, but I'm still having shortness of breath during the day, what else can I do? Well, instead of, increasing the use of your nighttime setting into the daytime for a few hours, If in the right setting for the right people, there is something called mouthpiece ventilation. Now, big exclamation point at the top here. This requires a ventilator. So you cannot do this with one of the simpler, smaller BiPAP devices. It requires a ventilator that's portable that has what's called mouthpiece ventilation options on it. And in addition to your nighttime setting, you can have an additional daytime setting. And what mouthpiece ventilation is it guides the tube using a flexible support arm to a mouthpiece. And the flexible support arm holds the tube in a position so that you can easily reach the mouthpiece, so that you're not getting a breath all of the time. It's only when you need it. You just take a sip from the mouthpiece or the straw whenever you want, and it'll provide a bolus of air anytime you need to help relieve that sense of work of shortness of breath and increased work of breathing. Some studies have looked at mouthpiece ventilation compared to wearing an NIV mask all day, and they found that it tends to decrease the psychosocial impact, decrease pressure sores on the skin, and can enhance speech. I've had a lot of patients who've had success with mouthpiece ventilation who have found that it helps them get through prolonged talking, helps them get through a meal, shortness of breath with regular activity, even such as transferring or bathing. I have a patient who is a teacher or teaches online, and they use mouthpiece ventilation to help them with the prolonged talking of, when they're lecturing for a while. So again, it's an as-needed bolus of air that helps fill your lungs with a nice, big, deep breath that can help take away that sense of shortness of breath and help strengthen your talking. I showed this slide earlier, but I hopefully through some of the slides, some of the recent slides, you've begun to understand some of the options for technology for home respiratory care. And I was going to cover just a few more if you'll bear with me. So what are the next steps? I talked a lot about where we are right now with home respiratory care, but where are we really going with all this? Well, what's here right now and is becoming more and more used as time goes on is remote monitoring. And that's fed into a lot of questions that we can begin to answer and analyze by developing clinical research. The remote monitoring involves collecting the data. So your breathing machine, the ventilators and the smaller BiPAP machines, they collect data every night when you're using it. How many times you breathe a minute? How big your breath is? How is the leak at your mask? What's your breathing rhythm look like? What's the size of your breath? And all these things are collected by the machine. And now what they've developed for some of the home devices is an online data portal that through cell phone signals to a modem next to your machine can collect the data on a daily basis. Then, if connected to your physician's account, your doctor can log in and see your data as recently as 1 day ago. And that can be incredibly helpful for seeing how well you respond when they make a setting change, or seeing how, if you're calling and you feel like you're not comfortable or something new is going on, they can review this data and it helps them narrow down and hone in on what the true issue is rather than trying to guess. And so this has been an incredibly useful tool in our clinic for helping patients get on the right settings that are comfortable and work for them. There are ways to actually check your FVC or your breathing strength at home. There is a couple companies actually. One of them is shown here. One is called Mirror that makes a Spirobank smart home spirometer that can connect to an app on your phone. So if monitoring your breathing is important to you, this is an option. Last I checked is It costs approximately $150, but I'm just putting this out there as an option, again, along the lines of remote monitoring. And then additional option now that we've been using in our clinic for several years is the ability to measure that gas earlier that I mentioned, carbon dioxide or CO2. Remember how I mentioned that it's very common for a hospital or doctor's office to have an oxygen sensor, but not every clinic has a carbon dioxide sensor. And what we're primarily talking about here is elevations in carbon dioxide. And now we have the ability to do this using the device shown here, where it's a sensor that rests on the surface of the skin, no needles, and can measure your carbon dioxide level while you're in clinic or while we have you on your ventilator and we're changing the settings. As an example, this is a picture of a patient shared with patient permission. This is a common scene in our clinic here where this man brought in his ventilator. We often do ventilator adjustments and titrations in the office. And he's on his ventilator right now with his own mask. And at the same time, we have this transcutaneous carbon dioxide or CO2 sensor on his skin. It's actually resting on his earlobe where my arrow point is right now. And that's showing us his simultaneous carbon dioxide levels and oxygen and heart rate while we adjust the settings on his ventilator. So it actually gives us a direct feedback for how these new settings are working for him as we adjust the settings. So what more can I do? I'm here, I'm learning. What can I do going forward to help be more proactive about my respiratory health? Well, I first and foremost want to applaud you because I think the most important thing you can do is arm yourself with education. I think education is one of the most powerful tools on earth. And by attending talks like this, you're arming yourself with information that can help empower you. There's a website out there done by a group in Canada that I think does a really good job of covering a lot of the different concepts and options and even additional options that didn't have time to get into today. And that's the CanVent Ottawa group. The website is canventottawa.ca, or if you just Google CanVent Ottawa, it's usually one of the first links that come up. And it's a group led by one of the doctors up there, Doug McKinn. His group has a lot of education modules on that website for you and videos for you to poke around on and learn more. And talk to other patients with your condition, how they manage their breathing, what are they using, what's their doctor recommending. Talking to each other, forming a sense of community, I think can be really helpful for opening up yourself to ideas and questions that you may not have thought about. Speak to your neurologist about what are the local pulmonary experts who know how to manage neuromuscular disease. I'm a board certified pulmonologist, but I can tell you that care for neuromuscular disease is not necessarily one of the front and center diseases that you learn about when you get your pulmonary training. It's a unique set of skills. You need somebody who has experience. So do the work to try to find who the local pulmonary experts are. Alert your doctors if you have any of the signs or symptoms of weakened breathing that we talked about. Remember, the early signs are disrupted sleep, waking up with headaches, daytime fatigue, trouble lying flat, a weakened cough. And if this is happening, make sure you're getting regular breathing tests. You should be seeing your doctor regularly and getting breathing tests on a regular basis, depending on how rapidly progressive your disease is. But typically in ALS, you're usually seeing your neurologist approximately every 3 months. And that's a reasonable interval to be doing spirometry unless you have something new or new symptoms going on, in which case you should get your breathing tests updated. If you're already on non-invasive ventilation already, don't forget about additional options such as cough assist or daytime mouthpiece ventilation if it's appropriate. As I mentioned before, it's for the right person, it can work out, but it's not necessarily for all people. Lastly, I just want to take a moment. This is the end of my talk, but I want to make sure that I have a moment to give thanks to those who made it possible for me to be here today. And first and foremost, that's to all of you, the patients, the caregivers, for you to take interest in your disease and become proactive. And again, arm yourself with education, I think is a beautiful thing. And so I applaud you for being here. I learned a lot by giving these talks. And so again, I thank you. I also want to thank the Muscular Dystrophy Association for inviting me out here. I always enjoy giving these talks and talking to other people. And I also want to thank those who work in the Penn Home Ventilation Clinic with me, as shown here on this list. My research mentors, my research is in respiratory care of individuals with ALS, and Dr. Steve Kaywood. And my funding sources who fund my research, including the Muscular Dystrophy Association. I do appreciate all the support. And with that, I will stop sharing my screen and see if anybody has any question.
Thank you so much, Dr. Ackrivo, for sharing all that information, some wonderful information. We did have a few questions that came in earlier, and then if anybody here has any questions, feel free to put those in the chat. So somebody has asked, when will I need to start using a respiratory device? What are the signs that my caregiver or I should watch out for?
Okay, so when do I need to start using a respiratory device? So the short answer is I'm obviously biased, but the short answer is I would recommend using it as soon as you can. But it's a question of when would insurance pay for it? Typically, insurance will only pay for these breathing machines when you meet one of the criteria that I mentioned earlier. And I think we're going to be sharing the slides, but the forced vital capacity below 15%, the MIP cutoff, if you can't get at least -60, or if they do the overnight pulse oximetry and your oxygen's going low enough. But sometimes if you're symptomatic enough, if your breathing is bothering you enough, your doctor might be able to make a good case with a well-documented note that even though you don't meet one of those cutoffs, you have ALS, your breathing is getting weakened, you need to be on one of these machines. Sometimes you can get it covered even before you meet one of those magical criteria. So short answer, as soon as you can, especially if you're already starting to have symptoms during the day, I think it's reasonable to try to talk to your doctor about what they can do to do the right paperwork to get you on one of these machines.
So it's really, really important, even if you don't meet those criteria, that good relationship with your doctor can kind of help you possibly get the device that you need.
Correct.
Okay. Somebody has asked if you have any advice on dealing with the anxiety that can come with those breathing issues.
Yeah, that's a fantastic question. I think having shortness of breath is one of the most terrifying symptoms. And it can be a self-fulfilling prophecy where you have shortness of breath, it makes you anxious. When you get anxious, you kind of change your breathing pattern. You might even start breathing faster or notice you're breathing more. And then that makes you more anxious, and all of a sudden you're going in a circle. Stopping that cycle is not always so easy. I would say that first and foremost, you got to talk to your doctor about it. Sometimes using these breathing machines can be helpful because it could be a symptom that maybe you're not getting enough support for your breathing and your settings could be adjusted, or you could be using a machine more. I've had some people use their machine for brief periods during the day to help with shortness of breath, even if it's related to anxiety. And then beyond that, there are medications for anxiety, but I think it's just also realizing that, some of this could be driven by just your thoughts that are racing, thinking about the breathing. And so recognizing that in trying to do what you can to stop, if you can, stop perseverating on it and focusing on trying to calm down your breathing, there are actually breathing exercises that you can do, diaphragm breathing exercises. If you Google that, there's a lot of resources out there for diaphragm breathing exercises that can help regulate the rate of your breathing, which can actually make you more calm. And so it's hard for me to go into too much detail without taking up the rest of the 4 minutes. But there are breathing exercises as well that you can do beyond the breathing machines, medications, and just an overall awareness of the fact that anxiety and shortness of breath can actually feed into one another.
I'm glad you discussed that because I know that personally when I am sick and it makes me feel short of breath, it's like the more you think about it, the worse that it gets.
Very
Looking
common.
into those breathing exercises can be very, very helpful. So thank you for that.
Sure.
Last question that came in, and I don't see any. Oh, somebody did just ask one in the chat. When doing overnight monitoring, does it require a consecutive 5 minutes?
No, it's just 5 minutes total throughout the whole night.
Okay.
Yeah. And there was a comment about having no symptoms, yet the oximetry was abnormal. I think that's a really good point. That you can have, and that's one of the points I raised earlier, how the weakness of your breathing can be super subtle at first. You might not have any daytime symptoms. It flies under the radar overnight. And unless you get an early overnight test, like the overnight pulse oximetry, you might never know until your breathing advances to the point where it's spilling over into the daytime. So it's actually that means that you just got the testing done at the right time. It was very early, but I'm not surprised. It's not too uncommon that people without symptoms can actually have abnormal breathing overnight at the right point in their disease.
Okay. All right. Thank you. I think we have time for this last one that came in. If I'm short of breath, should I use oxygen?
Oh, I'm really glad you asked that. I should probably put a slide in about this. So remember the slide that I put in earlier where weakened breathing causes first elevated carbon dioxide. It doesn't affect the oxygen first. It's elevated carbon dioxide. When carbon dioxide gets high enough, it crowds out the oxygen and your oxygen levels go low. And so it's very common that you go into an average doctor's office clinic visit or hospital and they have an oxygen sensor, but almost no one has a carbon dioxide sensor. It usually requires a complicated blood test. And so they recognize the low oxygen and they treat that low oxygen level with supplemental oxygen. But the primary problem, the primary drive, that's like putting a band-aid over a wound. You're not actually treating what's going on. The primary driver is the high carbon dioxide. If you give somebody with high carbon dioxide supplemental oxygen, you can actually make the carbon dioxide levels worse. And so something I teach my fellows and residents and students is someone with neuromuscular disease should almost never be on just supplemental oxygen without considering use of the BiPAP machine or a ventilator or checking their carbon dioxide levels first, because it can make the carbon dioxide level worse. So I would advise not using supplemental oxygen unless you have another disease that's affecting your lungs other than ALS that would give a reason for why you have low oxygen.
Well,
It's a really important point.
Didn't expect that to be your answer, so I'm glad that we asked that question.
Yeah.
So it is now 7 o'clock, so we do want to be respectful of everyone's time, but we did get through all the questions. So again, Dr. Ackrivo, thank you so much for being here. We so appreciate your time, your expertise, and everything you do for the neuromuscular community. We love having you, and we hope to have you again soon.
Yeah, thanks for inviting me. Thank you all for being here.
Just a few quick things to wrap up. I would again like to thank our webinar supporters, Cytokinetics and Mitsubishi Tanabe Pharma America. We would not be able to provide community education webinars like this if not for their generous support, and we are so thankful and appreciative. If you're new to MDA and are diagnosed with a neuromuscular disease under MDA's umbrella, or are a loved one of someone who's diagnosed, we encourage you to stay engaged with MDA. You can do this by visiting mda.org/join and completing a short form. Joining is free, and we'll keep you up to date on the latest research, educational programs, and supports. We would love to hear your comments about this webinar, so if you have a smartphone, you can open your camera and point it at the QR code on the screen. That'll pop up a web page with a short survey. If you don't have a smartphone, that's okay. You'll get an email with the link in it in just a little bit. If anyone has questions after this webinar, please feel free to email them to mdaengage@mdausa.org, and we will follow up with you. So this concludes week 3 of the ALS Virtual Learning Series. We're so glad you joined us tonight. Dr. Ackrivo, thank you again. We hope to see you next week. Next week, we will be having a discussion on financial planning. So I hope you have a great night, and I hope to see you next week. That concludes today's webinar. Thank you.
Take care, folks.